Namaste everyone. Myself, Dr. Kalpesh Kavar, consultant diabetologist from Rajkot, Gujarat. Today, in this podcast, we are going to discuss about diabetes. One interesting case we'll discuss, and then we'll discuss about how we should go for the management of diabetes for such cases. So let us start with this interesting case, who is a 50-year-old type 2 diabetic patient for last 2 years. That patient came with the frequent hypoglycemia events in the past 2 months. His current medications, he is taking metformin 1000 milligram twice a day, along with sulfonylureas, glimepiride 2 milligram twice a day. His reports are HbA1c of 8.2, which is of uncontrolled blood sugar, uncontrolled diabetes, with the recurrent episodes of hypoglycemia. His creatinine value, EGFR, lipid profile are within normal range. His physical examination, his BMI is high, that is 31 kilogram per meter square. His blood pressure and pulse rates are normal. So if we discuss about this case, here our primary treatment consideration should be to have a optimal glycemic control with the cardio-renal protection. So the overall HbA1c goal for such patient would be less than 7. Sometimes on the basis of provider judgment and patient preferences, HbA1c even lower as 6.5, less than 6.5 may be acceptable if it can be achieved safely without significant hypoglycemia or any other adverse effect of treatment. So in this case, when his HbA1c is of 8.2, which is not in target range. So target range should be less than 7, and if achievable less than 6.5, better. If we talk about in a current situation in a 21st century, type 2 diabetes has reached epidemic proportion globally. India, we have a tendency for early onset of diabetes, leading to accelerated risk of developing associated complications, making it more essential to address this pathology early in the disease course, with the available novel therapies having a minimum risk of adverse events, including a hypoglycemia. So strict glycemic control is critically important in patients with type 2 diabetes. Sulfonylurea plays a pivotal role in glycemic control as a direct extension of their mechanism of action. However, the risk of hypoglycemia with sulfonylurea is increased, and this risk may further increase in patient with renal impairment, which is now a common comorbidity associated with type 2 diabetes. Hypoglycemia is a major concern for the users of a sulfonylurea, and magnitude and severity of sulfonylurea induced hypoglycemia range widely across the studies. There is a strong rationale for a combination of DPP4 inhibitor and cardiovascular protective class of SGLT2 inhibitor in patients with type 2 diabetes, because two drugs exert a different and complementary glucose lowering effects. Furthermore, the increase of glucagon level induced by SGLT2 may be blunted by co-administration of DPP4 inhibitor. The clinical evidence shows that the combination of SGLT2 inhibitor and DPP4 inhibitor is an effective option for the management of type 2 diabetes, providing the HbA1c reduction required is between 1.1% to 1.5% and weight reduction of approximately 2 to 3 kgs when added to metformin, which is its primary place in the therapy. Now, ADA, which is American Diabetes Association, recommends initial combination therapy should be considered in patients presenting with the HbA1c level of 1.5 to 2% above the target level, considering the absolute effectiveness of most oral medications rarely exceeds 1%. So this unique combination leads itself readily to the early treatment intensification because of good tolerability, lower risk of a hypoglycemia, possible advantage of a weight loss, and minimal treatment burden. Clinical experience with DPP4 inhibitor and SGLT2 inhibitor combination shows that they can be used with a good safety profile and a low risk of adverse events, including hypoglycemia and weight gain, even when added to metformin, which is particularly important finding for clinicians. Apart from that, a reduction in incidence of genital infections associated with SGLT2 inhibitor can be reported when a DPP4 is added, perhaps because of better glucose control along with other possible mechanism remain to be investigated. So overall, if I conclude, early intensive good glycemic control along with cardiorenoprotection can be achieved with a proper selection of group of medicine based on individual requirements. So that is all about our today's case on type 2 diabetes who is uncontrolled. Along with that, there was a recurrent episodes of hypoglycemia. So we can address both the challenges very effectively if we choose the right group of medications.